of all, there is nothing that I have to disclose today about either the content or any specific items in this presentation or the presentation itself. This presentation was prepared by Dr. Mealy or Dr. Lindsay and Dr. Bott. And the topic for today is substance use disorder assessment and screening, and the importance to integrate that into the care that we provide, regardless of what discipline we are. So whether you are a psychologist, a physician, a social worker, a peer, the utility of including assessments and screenings. And hopefully at the end of this really brief presentation, you'll be able to see the importance of including these items in your treatment, describe some recommended models that you can use when you're screening and assessing, and then look at some common tools. This is not meant to be inclusive of all tools that are out there for assessment. So there are more, and sometimes there are more updated ones. So please keep that in mind. I hope that at the end, really you feel curious as to how to include that in terms of your in terms of the care that you provide. And why do we talk about that? If we look at the statistics when it comes to substance use and alcohol use, the rates are pretty high, even starting as young as 12. And so we want to capture as many patients, and most of our patients might not start seeking treatment in a substance use disorders treatment facility. They might actually start in a primary care setting, right? And so if you look at of all the people that are using, we have about 23 million who are needing treatment for substance use disorder. In other words, they've actually now met criteria for a substance use disorder, right? And actually of that 23, about a very small portion, only just a little bit above 10%, receive the treatment that they need. So we'll talk a little bit about even matching services. One might be an approach that we use here in New Mexico, along with other states where this is mandatory. And then, of course, understanding that there's a lot of stigma, right? So that even though when a patient is going to talk to their primary care physician about their concerns with any overuse or addiction about a specific substance, that even as providers, we have stigma that that comes across, and then our patients then shy away from seeking services. So if we use methods in which we're asking questions that are culturally sensitive, that account for other aspects that we might not be as aware in just asking, then we definitely improve the chances that somebody will look and seek treatment. And as I mentioned to you, primary care, we have a pretty large percentage of individuals that come through primary care that are coming in not just for primary care issues, but mental health issues and substance use, or a combination of the two. And so what a great practice to have tools that can at least become screeners and kind of alert us that we might be having to assess a little bit more further mental health issues or in substance use. Okay, so in the next one, so we again, why not only does it help us to be able to capture the ones that come through primary care, those patients that come through primary care, but it also helps us to see what are the services that they need. Not just, for example, if you're a physician, not just the medication, but maybe the therapy, maybe the coordination, care coordination that will help them to succeed. If you look at the way that we used to approach treatment, it used to be very connected to that acute episode, right? or that relapse when that person was in acuity because of a relapse. So so we often have seen that, when we often use these kinds of models, we were seeing substance use disorders as more of a one-time thing, right? Just that acuity. And instead, if we have more of a chronic approach, right? If we realize that it's not just about treating our patients when they are in that acute point, but also when they're doing well in putting preventive measures, then we were able to provide a more holistic care. And ultimately, our patient will be more successful in their own care, which takes me to this next, the next slide, which talks about episodes of care. I think very often, like if we think again of the first model of just the acuity, then we become very dependent of the different systems, because when we feel really ill, then we just go and find help, and then we're doing well, we don't look for help, and then when we feel very ill again and we look for help, rather than putting in some preventive measures. If we start viewing, especially in particularly substance use disorders, as a chronic illness, then we know that we're putting things in place to start preventing the next lapse or relapse. And we start to do such a good job in putting preventive measures that those acute episodes start to not be as acute. So maybe your patient came in with an acute episode way up here, the next one over here, and so forth and so on. And the way that we reduce the peak of those acute episodes is by being able to put in place other tools. So how do we do that? We can think of episodes of care, right? We are working collaborative with those patients so that they themselves know what are the things they can do. We can share tools with them, and then they can choose from those tools what are the ones that work best for them and how they can use them. I think this notion that this older notion of more of a paternalistic view where we just tell our patients what to do and we know best, we can see that that hasn't worked as well, right? Because there are things that we're not accounting that our patients are experiencing within their communities, barriers, systemic barriers, environmental barriers, etc. So if we look at episodes of care, then we have this understanding that a patient might come in and see me for a certain amount of sessions for me to be able to provide something that I'm an expert in, right? And that if there is something else that the patient needs, let's say, for example, they're trying to navigate the healthcare systems and they feel very lost, that then I will find somebody to refer them to, and I'm working with the patient as I'm referring them to, so that they can get connected, say, for example, to some program like the one we have in the hospital, Care Link, where they're helping the patient navigate these systems to reduce those barriers. And then as we're working and putting in some type of system to navigate, we're also working with a patient to maybe address something that relates to primary care, or maybe something that relates to mental health issues. And so each one of us in that team are providing episodes of care collaborative, right? And so that's the continuum of care. That if I treat a patient, it doesn't mean that I just do my job, done, patient is gone, and hopefully they'll be okay. I leave everything to luck, right? We're all connected. We're all providing different levels of care and different types of care. And we're going to look at ASAM criteria, which is a very helpful approach. But again, when we're using measures, when we use screeners, questions that have been standardized, then we can find out whether or not our patients need something and at what level do they need. So this is just a graph to show that. One way to go about that is to use the ASAM criteria, which is put out by the American Society of Addiction Medicine. And it's a very specific way of collecting data and then putting that data into where would the patient be best served, considering 6 dimensions. And one of the things that's really interesting about the ASAM criteria is that the newest book, it's compliant with the DSM-5. It actually includes information about specific populations. For example, if you work with adolescents, it tells you how how to gather, what data to gather, and then what are some of the things to consider in terms of treatment. It includes disorders that we don't typically see in most substance use disorders clinics, like tobacco use disorder, gambling, etc. And then like I mentioned, it has specific populations. If you look at this map, what's really interesting about the ASAM criteria is that it's not required or it's not used by all states in the United States. New Mexico, it is required. So for example, here at ASAP, we have it as a patient comes in to get treated within the different systems, we have pieces of it to be able to gather that data and to be able to put that patient in a track that would best help them. In conjunction with other so to speak, complementary services, right? So that may be case management, that may be psychiatry, that may be primary care. So it's important to note that. I noticed that there are a few people here from Texas. Texas uses a different criteria than ASAM. In the ASAM criteria works this way. So the patient comes in, we use, I apologize. Let me see, let me go back and forth. I'm not sure why, is that little link? Okay, there we go, sorry, apologies. So we have 6 dimensions, right? So we collect information as to where is the patient when we're seeing the patient and we're gathering information. Are they in an intoxication state, in a withdrawal state? How did they feel about treatment? I really like this model because that's one of the aspects that it's very important. Talk about that collaboration, right? We want to know if the patient feels like they really want to engage and they're ready to do some things. Biomedical, are there some issues that we should be considering? Maybe they have an uncontrolled diabetes or high blood pressure. Does that need to be addressed first before addressing anything else? Relapse potential, right? How much at risk are they? And then notice that there's that emotional behavior, understanding that substance use disorders very often go hand in hand with mental health issues. So are they experiencing depression, anxiety, etc.? And what is the environment like? Is it an environment that's conducive, or are they in a place where it actually puts them at a higher risk, not only for relapse, but also safety? So once that information is gathered, then we're able to decide, make an informed decision as to what type of level of care. Is it outpatient? Is it inpatient? And if it's inpatient, what type of care? And if you notice in the actual full spectrum of continuum of care, there are even decimal points added to be able to include maybe more specialized treatments that can happen before even sending somebody to inpatient. So for example, between outpatient and inpatient, you can have something as IOP services, right? Intensive outpatient services, where the person is okay, still functions well outside, but it's receiving very intense services. Like for example, in our clinic, patients end up having to attend 3 times in a week for about 3 to 4 hours. And they're receiving all kinds of therapies that are helping them build up those skills to be able to be successful. The beauty of matching services, and again, I apologize, if what this graph is talking about is when the services are matched in general, and in this particular study in relation to cocaine and heroin, when the services are matched, then people tend to stay longer in treatment. And then, of course, the longer they are in treatment, the more successful they can be with issues with relapse. So for those of you, if you don't know, for those of you who are in New Mexico, if you don't know if your organization uses an ASAM criteria, you may want to ask, especially for those of you who are in training, in terms of the places where you're either doing internship or moving on, to see how is ASAM criteria incorporated, because this is one model. It's a very, very robust type of or approach to be able to determine services, because it has a very strong face validity, reliability, and feasibility, and there have been studies that show that that it helps individuals to stay within treatment. Another approach is the SIBRT model, and it stands for screening, brief intervention, referral to treatment. And just as each of its letters indicate, right? You start by screening, and you take that opportunity to actually do a brief intervention, so it can be done in whatever setting you're in, and then making sure to use tools to be able to figure out how to refer to treatment, right? So you can use specific tools that your organization has or uses that are standardized, or you can use ASAM criteria to be able to determine what services. Here are the elements in terms of the brief intervention. Again, what's nice is that you're actually working as soon as you're doing as soon as you're collecting information, as soon as you're screening, you're moving on, and you're actually ensuring that you're matching services. Let me make sure this shows, so that you determine, do I need to provide prevention at this level, right? There are very low risk, or education, or at this point, do I need to start moving towards motivational interviewing, brief motivational interview, or MET, or are we at a point where we definitely need to follow up a very specific high level of care, right? So that's in terms of how do we gather that. Screening tools, just remember that the main purpose of screening tools is to let me just click on this. It's to be able to target behaviors that, again, now have become a pathology, and it is very goal directed in order to be able to see what's the next thing. Again, notice the screening tools generally tell us yes or no, meaning somebody might have an issue. So we might need something to do further assessment to be able to determine if that individual meets criteria for what we've been screening them for, right? And so, but if we don't ask in screening, using screening tools, then we won't know that there might be even an issue, and we might not even notice that perhaps somebody is drinking at a point where it's affecting their daily life. Okay. Differences, we talked a little bit about that. The screening tools generally, as the person is coming in, we have questions. Sometimes they tend to be 1, 2, 3, 4 questions, very brief, in order to be able to determine, is there a problem? Should we ask further? Should we collect further information? Where the assessment is the next step of the screening portion, right? At that point, then we're collecting further information that can help us determine what criteria. So if we're saying somebody meets criteria for alcohol use disorder, is it moderate, is it mild, is it severe, is it in remission, etc. Here's a list of commonly used screening tools. We have a couple of examples in the PowerPoint. Like, for example, the cage. If you notice, let's see, it has 4 questions. It actually shows patients what do we mean by drinks. So that's very important too, to operationalize amounts of whatever we're measuring, right? So that we can determine if it is at a point where it's higher than what the norm is. So here's the 4 questions for the cage, and it really is just yes or no. And again, this just helps us to determine that there might be something going on. Another tool would be the audit and audit C, which is a little bit shorter. I think it's 3 items for women and 4 for men, and the full audit is 10 items, and it can lets us know what is the risk for somebody who's drinking. Here are some questions, some examples of questions from it, and it's just asking them how many drinks are they at a point where they're using weekly, daily, weekly, and then are they to the point where other people are getting affected by their drinking. This is the other one would be the dust. And again, I'm hoping that you can see these items. You will get a copy of the presentations. Sorry, you'll get a copy of the presentations so that you can review them. I hope that you're using some of these tools. If not, hopefully some of these tools sound that they're very useful. So for example, we use the dust to be able to try to see how much substance use there is, up to what level. We usually use it to screen our patients about at the longest period would be every 90 days, but if not, a little bit more often. Especially you can use them too when you're working with patients, for example, in therapy, if you're trying to track, right? We have a couple of others, and I know we have the NIDA, the ASSIST, which measures alcohol, smoking, and substance involvement. I'm looking at time. And then we have the COWS and the CWA, which talk about withdrawal symptoms, right? So very often we, our medical side uses it to try to determine where patients are when they're getting treated for opioid use disorder. And I don't know, Dr. Bhatt, if there's something else to add, because it's a little bit more medical, the withdrawal and the COWS and the CWA.
No, I think that's good.
Yeah. And so here's some mental health screenings. Again, one of the practices that we've taken upon is to ensure to give the PHQ-9 is not, notice it's a screening tool, it's not a diagnostic tool, but it can at least let us know if somebody's struggling with depressive symptoms, and if somebody's having maybe some suicide or death ideation. Now, notice that that's not clear in the PHQ-9. So if we use that as a screener, then we're able to follow up with something like the Columbia to be able to determine if somebody at a really high risk. In therapy, the mental health screening tools can be really useful as we're trying to track across treatment whether or not we need to change something, right? So they're very, they can be very useful. Notice that there's a PC, the primary care PTSD. It's a 5-item. If it hits 3 and higher, then there's follow-ups, right? That's why we talk about assessments. The PCL5 will ask you a little bit more about symptom severity. It's not meant to be either a diagnostic tool, but it's more to see what's the severity that patients are feeling in terms of their PTSD symptoms. On the other hand, so those are screening tools, you have assessment tools, right? And one of the reasons why we consider an assessment is we want something that is very comprehensive for us to be able to develop a very clear case conceptualization to be able to determine what are we going to do, what is the diagnosis, first of all, nothing like having the correct diagnosis, so that our patients know what it is that they're dealing with. We know they very often go and look for resources or responsibilities to educate them about them, and then we can match that. Notice there are so many different areas that contribute to understanding what type of treatment do we provide. Very, very essential, like social history, legal history, education history, and employment, things that sometimes we don't think of. And let's see, I think there's a link in here. Okay, and then the one that I like about this slide is that collateral information. If you have the luxury to be able to ask family and loved ones a little bit more information about the patient, please include them, because it gives us a very different view as to what is happening in that patient, not just at this point during this acute episode, but throughout their entire lives, even when they're doing well. Because again, remember, patients are coming in when they're having an acute episode. So we really don't know what that baseline is, especially when that patient's coming in for the first time. So please, here are a couple more. Please consider including them as a way to be able to help you navigate what would be the best type of treatment. And for those of you who, like in Texas, even looking into what models are the models that you're using. I think that's it. The last slide is questions. And again, this is a super brief overview